going to have now the lung session, please. Will the chairpersons please come? Because we already have online with us the speakers. Please, Professor Abdul Muttalib Muhammad, Professor Nasreen Musallam, Professor Yasser Mustafa, Professor Hisham Tawfiq, Professor Amr Saqr, Nasser Abdul Bari, Professor Hisham Al-Wakil, Professor Nirvana Hassan. Please step to the stage, please.
Now we will start the session of lung cancer. I have the pleasure to introduce Professor Duru Muganaki. The topic will be technological innovation in thoracic radiotherapy of lung cancer.
Now, if the patient requires a salvage resection for failure after Sbrt, there is good news for some patients who Hello, my name is Drew Moganaki. I am a radiation oncologist. Today, my talk will be about technological innovation in thoracic radiotherapy of lung cancer. Here are my potential conflicts of interest. I will begin by covering the topic of radiation therapy as an alternative to surgery for stage 1 lung cancer. Many reports have shown that Sbrt can achieve the same outcomes as surgery for stage 1 lung cancer. The most recent and potentially most powerful paper was just published 2 weeks ago in Lancet Oncology. The group at MD Anderson enrolled 80 patients who were medically fit for lobectomy and received Sbrt, also known as Sbrt, in this trial. They matched the patients to 80 other patients who underwent a VATS lobectomy with mediastinal lymph node dissection at MD Anderson, so that we're looking at a comparison, non-randomized, of best Sbrt at MD Anderson versus best surgery at MD Anderson. As you can see, there's no difference in overall survival or lung cancer-specific survival. There were some increased progression events in the Sbrt arm, but after relapse was identified, systemic therapies were able to close the gap so that the outcomes were the same long-term. The best lung cancer programs have multidisciplinary teams where the different specialists get together and discuss all of the different challenges for the diagnostic workup, what to biopsy, how to finish the staging, and what treatments to deliver. And the question I always ask is the radiation oncologist in the room, what are they saying, and what do people know about radiation therapy? The journey of patients who are going to receive radiation therapy begins with the consultation, history, and physical. Next, they undergo a CT simulation to develop a three-dimensional map of the chest and the location of the tumor. The end goal is to get the patient to the treatment machine, which looks something like this, so that the treatments can be delivered. When we evaluate the CT images, we actually try to play a movie to generate the four-dimensional CT scans, with the fourth dimension being time. When capturing all the different locations that the tumor can be during different parts of the treatment, as you can see here, it is important to know so that you can encompass all of it and not miss the tumor during any part of the breathing cycle. Next, The treatment plan is developed, and for something like a stage 1 lung cancer, the treatment fields are small, but for more locally advanced disease, the treatment plan can be a bit larger. With the use of IMRT, you can at least make the treatment field compact to reduce the amount of normal tissues receiving the high doses of radiation. Once the treatment plan is developed, we evaluate the prescription in 3 dimensions by first looking at where the full 100% prescription isodose volume is being delivered. This is the dose that we believe is required to eradicate the tumor that's being targeted. An evaluation also should look at the intermediate doses of where there is some spillage in the intermediate dose range to evaluate where those doses are going to reduce the risk of injury. For patients who have larger volume disease, the radiation treatment plans can still be made to be compact to avoid treating unnecessary areas such as the contralateral lungs or the esophagus, and of course, using techniques to minimize overexposure of the spinal cord. By using conformal techniques, we minimize where the high dose is being delivered because it is actually the high dose that seems to cause the most problems. Radiation is also a great tool for taking care of patients who are suffering from uncontrolled disease, such as using photons for bone metastases with treatments as little as 1 fraction. Electrons are also a great option to provide superficial radiation so that you do not injure the lungs, for example, if the ribs are the target. For patients who develop brain metastases, we have more options than ever before. We like to use stereotactic radiosurgery to deliver higher doses to the tumor targets to get better long-term tumor control and avoid the use of whole brain radiation therapy, which can cause memory loss. Whenever we have to treat the whole brain, we can now avoid the hippocampus, which we believe is where the memory centers are, and at the same time, using IMRT technique, boost the areas that we can see to, again, deliver enough dose to avoid these tumors from recurring, especially if they have a long life expectancy. For patients with spine metastases, we are using conventional radiation therapy less often than ever before. The reason is because you cannot deliver a lot of radiation with older techniques where you have to put the beam through the bowel and the spinal cord. We now use Sbrt most of the time. This allows us to deliver more radiation to make sure that this tumor doesn't recur. It also reduces the risk of injury to the bowel and also side effects from treatment. The topic I want to discuss are the wounds that are created after Sbrt to the lungs. Here is one of my patients who I treated with Sbrt for stage 1 lung cancer, 18 gray times 3 fractions. At the 6-month mark, you can see the wound is starting to develop just outside the area that was targeted. By 12 months, it appears that the tumor has disappeared, but this wound has evolved and is undergoing inflammatory and fibrous changes. And by 15 months, this wound is not collapsing on itself, but it is assuring that it is getting smaller, but it's not reassuring because it hasn't disappeared. It's quite fascinating to see what happens to these wounds over time. I'm going to show you the pictures of a patient who lived 5 years without relapse to show how much evolution these wounds can have. Here is from the planning. This is the first 3-month scan showing some of this scar formation, and by 6 months, this seems to be disappearing. This black star here shows that this is an indication that is raising concern that the tumor may be progressing. More scans several months later shows that that thing gets smaller, smaller again, and then gets larger one more time at 30 months. Then it gets smaller, and then bigger, and then smaller, smaller, and smaller here at 5 years. This creates a lot of challenges, and the general practice should be that if you are concerned about relapse, to then get a PET scan. We do not surveil with PET. We only get a PET after the CT is abnormal. And then if we think about delivering any more treatment, we generally try to get a biopsy because we do not want to do surgery in someone with just a benign scar, such as a person like this. And there are publications that have shown benign scars coming out after salvage lobectomy. Now, if the patient requires a salvage resection for failure after SBRT, there is good news for some patients who fit the criteria for resection. In this report from MD Anderson, they pulled data from 4 institutions, 37 patients, half of whom were men. The median time from SBRT to failure was 16 months, and prior SBRT had been delivered for primary lung cancer is 70%, and for oligometastatic disease in 30% with thoracic SBRT. Salvage surgery was done sometimes with video-assisted thoracoscopic surgery, but most of the time it was an open resection. Extensive adhesions were found less than half the time, meaning the surgeries were straightforward in about half of the cases. Most of the time, lobectomy was the procedure, although sometimes sublobar resection was possible. Negative margins in all of the cases, and nobody in either of these 4 institutions of data died from a complication because they had received upfront SBRT. What's interesting is that after salvage resection, the overall survival was very similar as if they had upfront surgery instead of upfront SBRT, supporting the idea in the right patient, it would be appropriate to give upfront SBRT and then surgery later if there is failure. I next want to discuss the problem with ultracentral tumors. Central tumors are within 2 centimeters of the proximal bronchus. However, ultracentral tumors, which were defined in 2015 in this paper, describe the situation where the tumor is touching the proximal bronchus. There are different definitions that have been published, such as here that describes whether it's touching the trachea, the primary bronchus, or the secondary bronchus. In the report from Stanford back in 2015, it showed no severe toxicities in the 7 patients who they treated with SBRT with a median follow-up of 11 to 26 months. However, we are seeing that not everybody can produce these same results, and in a very important paper published this year by the Hylas group, we found that patients who had had ultracentral SBRT had severe complications in up to 10% of cases. What you see here are SBRT plans for 8 patients, and all of them died from grade 5 hemoptysis. There were patients who also had other complications from SBRT to ultracentral tumors, including fatal pneumonitis and fatal fistula. The paper is worth reviewing to understand what the technical limitations are, and we do have several letters written about this to help everyone understand how they can avoid this sort of problem in their clinic. At the end of the day, it should be considered dangerous to deliver SBRT for ultracentral tumors until better techniques are discovered. For lung tumors that are central or ultracentral, one of the best things that we can do is to use IV contrast. Here you can see the images on the left and the middle do not have IV contrast, and it's unclear what to contour. On the right, you can see with IV contrast, we would draw probably half the volume and minimize the amount of radiation delivered. This improves safety. Other more modern techniques allows better image guidance, such as with MRI, where you can see the tumor while the beam is being delivered. One of the machines that can deliver MR-guided therapy here has created a video that shows how you can see the tumor and turn the beam off and on only when it is appropriate to make sure we treat the smallest area needed. The final topic I wish to discuss is the problem with patients with metastatic disease who have limited options for systemic therapy. In patients with metastatic disease who are on drug X, when drug X stops working, they usually switch to drug Y, and then drug Z, and then there are no more options. But what if we were to get more mileage out of drug X by treating the lesions that aren't responding? So the medical oncologist is worried that drug X isn't working, You use local consolidation therapy. This increases the amount of time and pushes out the time before you give drug Y or drug Z. Aggression. Once again, local consolidation therapy with radiation can increase the amount of mileage on drug X, again pushing death out farther and farther. There are now new words in the literature to describe the oligometastatic setting where local consolidation with radiation might make sense. For example, patients who have, while they're getting systemic therapy, oligopersistent disease, also known as oligoremnant disease, or they may have oligoprogression or oligorecurrence. The definition of oligo basically means just a few. How many that is up to each physician to make a decision for themselves. There are two key randomized trials worth knowing about, called the Oligomes Trial or the Sbrt Trial. These studies were small, but the effect sizes were large. On the left, you will see that with the addition of local consolidation therapy with radiation or even surgery in some cases, we had a significant prolongation of survival for overall survival and progression-free survival. And in the Sbrt trial, again, you see a significant improvement in outcomes when delivering local consolidation therapy. I have just a few take-home messages to finish my talk. Number one, radiation therapy is a simple and powerful tool for lung cancer. Number two, Sbrt is safe, but not always with ultracentral tumors. And finally, number three, radiation therapy can help people with stage 1, 2, 3, and 4 lung cancer live longer. Thank you.
Discussion? Okay, now it's my pleasure to thank you so much, Professor Mohanaki, for this elegant presentation. Now we will go for the next session, which by Professor Ramalingam, Professor of Hematology and Medical Oncology. He will talk with us about the updates in the management of the metastatic non-small cell lung cancer.
Dear colleagues, I want to start by thanking the organizing committee for the invitation to speak at this International Oncology Conference. I'm honored for the invitation. Today, I would like to talk about recent advances in the treatment of metastatic advanced stage non-small cell lung cancer. These are my disclosures. So the first point I would like to make is that we're making great progress in the fight against lung cancer. We're seeing reduction in mortality related to lung cancer. United States numbers for lung cancer mortality in men, in the past 20 years, there has been a substantial reduction. Just in the past 5 years, we're seeing almost a 3 to 4% reduction in mortality every year for lung cancers. Now, these are just United States. It is our hope that what is changing the outcomes here will soon start having an impact in global lung cancer mortality, and therefore patients across the world will benefit from the exciting advances that have been made in the field in the past few years. Now, when we look at what are the major drivers of this reduction in mortality, I have listed about 5 points here. This is not an entirely complete list, but certainly it provides us with some of the key reasons why we think mortality related to lung cancer is reducing. The first, of course, is early detection of lung cancer through CT screening is now possible, and this in fact has a result of reduction in mortality. We know that lung cancer mortality can be reduced by approximately 20% for patients who were detected with lung cancer by screening. I would say that screening is still underutilized for lung cancer, not just in the United States, but all over the world. And this is something we all need to work on as a community to screen high-risk individuals for early detection of lung cancer. The other major advance is that we understand lung cancer biology much better. We know the molecular drivers that result in cancer, and therefore there are multiple treatment options that can be used to modulate these pathways and therefore induce better patient outcomes. Immunotherapy and targeted therapies have become part of routine management of lung cancer. And both of these approaches help patients live longer and live better. So use of these in appropriate patients based on biomarkers is making a big contribution to improved lung cancer outcomes. Now finally, we're beginning to use plasma ctDNA to guide therapy for lung cancer. And while we're still in the early days of that, we're seeing this can be used effectively for molecular diagnosis and also to make treatment choices based on the NGS testing of peripheral blood. So I'm going to elaborate on some of these in the next 15 minutes and show you the kind of advances that have been made in lung cancer. This slide shows the new agents approved by the United States FDA for lung cancer just in the past 5 years. When you look at the top half of the slide, these are agents that target the human immune system, specifically the PD-1, Pdl1, and CTLA-4 pathways. In the lower half are orally administered tyrosine kinase inhibitors that target various genetic drivers that are seen in lung cancer. And as you can see, this list continues to grow by the year. Just this year, the FDA has already approved close to half a dozen new indications for lung cancer. So using targeted therapies, using immunotherapies are appropriate for patients with metastatic disease based on specific biomarkers. So that's clearly a major reason why we're seeing improvements in outcomes. Now, just in the past 1 year, we've seen a number of phase 3 and large phase 2 trials report out the results, which are promising. These results have been reported in multiple international and national conferences, including the World Conference on Lung Cancer, ASCO, and the ESMO Congress. We've seen randomized trials of ALK inhibitors, we've seen EGFR tyrosine kinase inhibitors, and we are seeing some novel agents that target genomic drivers such as KRAS G12C and HER2 mutation. There are also combination studies of immune checkpoint inhibitors that are making their way into the treatment paradigm for lung cancer. Now, presently, when a patient is diagnosed with metastatic non-small cell lung cancer, molecular testing is considered critical. Even before we start any patient on therapy, we do next-generation sequence testing of the tumor tissue. We look for various driver mutations. What you see on this slide in the orange boxes are driver events for which there is an FDA-approved or an effective treatment option. Primarily, these targets are seen in non-squamous non-small cell lung cancer. So if a patient has non-squamous lung cancer, we would definitely recommend NGS. In squamous cell histology, the role of various drivers has not been sufficiently useful for developing treatment options. So we don't routinely do this, but if there is a never smoker who has squamous, certainly NGS testing is appropriate for that patient. We also look for Pdl1 expression. Ideally, these markers are done on the tumor tissue. Pdl1 expression certainly requires tumor tissue. Now, liquid biopsy or plasma ctDNA testing can provide NGS for genomic drivers. So if tumor tissue is not available and if repeating the biopsy is not an option for a given patient, then we can certainly use peripheral blood for ctDNA testing. It's fair to say that the NGS testing has already changed the treatment landscape. We can now do tissue-based testing or peripheral blood-based testing. Tissue-based testing has many advantages and some drawbacks. Same with ctDNA liquid testing, where there are some disadvantages and advantages. It's likely that in the future we will use both, because in about 10% of the patients, drivers that are missed by tissue-based testing can be detected in liquid testing, and drivers that are missed in the liquid can be detected by tissue-based testing. The tissue-based testing is subject to tumor heterogeneity. If we biopsy one part of the tumor where the mutation is not seen, then we're going to miss that. Whereas ctDNA-based testing can pick the tumor cells, derived DNA, no matter where in the tumor these mutations are enriched for. Obviously, liquid-based testing has lower sensitivity compared to tissue-based testing. So if the liquid is negative, we would still require tissue to confirm. But if the liquid shows positive, say, EGFR mutation, we can use that information to make treatment decisions then and there. We learned a few years ago that for patients with driver mutations, using targeted therapies results in better outcomes. These are results from the Lung Cancer Mutation Consortium in the United States, where patients were categorized as those with driver mutations that received targeted therapy, those with driver mutations that did not receive targeted therapy, and then the third group of patients did not have driver mutation. And when you look at the survival curves, the light blue, which is the best outcome among these three groups, which has the best outcome among the three groups, shows that patients with the driver mutation who receive targeted therapies have better survival outcomes. And this is the main reason why we should look for these targets before we start patients on targeted therapies. The good news is now for patients with non-squamous non-small cell lung cancer, nearly half of them, 50% of the patients, could have a driver mutation that's targetable. Now, I understand that some of the drugs that you see on this slide are not available all over the world. These are United States data. Certainly, we have very good data to support the use of these medications, and it is only a matter of time before they become available in other parts of the world as well. For mutations, nearly half the patients with non-squamous non-small cell lung cancer. And this slide shows you some of the various treatment approaches that are available to get this therapeutic benefit. Now, one of the examples I will talk about is EGFR mutations. EGFR exon 19 or 21 mutations are common in about 15% of the Western population and about 35–40% of Asian patients. For these group of patients, we already showed that using osimertinib, which is a third generation TKI, resulted in a favorable progression-free survival and overall survival when compared to gefitinib or erlotinib. These are the survival curves that show that there is nearly a 7-month improvement in overall survival. Now we're doing studies to combine osimertinib with chemotherapy. There are also osimertinib-based novel combination approaches. And when patients develop acquired resistance to osimertinib, there are now new approaches that are being studied in clinical trials. Similarly, for patients with ALK gene rearrangement, there are very highly effective ALK tyrosine kinase inhibitors. Brigatinib, alectinib, and lorlatinib are all superior to crizotinib. Serotinib is also superior to crizotinib. And these three agents have shown very promising results, not just systemically, but also in the brain. So for patients with sub-centimeter brain metastases, we don't even offer brain radiation if they are asymptomatic and just start them on TKI. And the survival for ALK positive patients, the median survival is now approximately 6 to 7 years for metastatic cancer. So clearly we're making progress in this subgroup of patients who account for nearly 4 to 5% of lung adenocarcinomas. For a long time, we've had some targets that have been difficult to treat. One of them is KRAS mutations. KRAS mutations account for about 25% of lung adenocarcinomas. Now, KRAS mutation is not one entity. There are different subtypes of KRAS mutation. The G12C mutation accounts for nearly 14% of patients with lung adenocarcinoma. For this group of patients, the good news is we now have promising targeted drugs. These are orally administered small molecule inhibitors. Sotorasib is the first one that entered the market in the United States. It has a response rate of nearly 37%, disease control rate of 80%, and a median PFS of approximately 7 months. Adagrasib is another drug that is being developed for KRAS G12C patients. It is not yet approved, but it has also shown promising results. So we're now using G12C targeted therapies for patients with advanced stage lung cancer. So we now have shown that targeted therapies are appropriate for patients with genomic drivers. And in fact, there are multiple studies that show that for a patient with a driver mutation that can be targeted, their first-line therapy should be targeted therapy, not immunotherapy, not chemotherapy. In fact, even if the Pdl1 expression level is 100% in a patient with EGFR mutation, TKI should be the first-line therapy, not the immune checkpoint inhibition. Now let's switch gear and talk about the other 50% of the patients where there are no targetable drivers. For these patients, now we use PD-1 or Pdl1 inhibitors. This cartoon shows the mechanism by which PD-1 and Pdl1 inhibitors work. What they do is these monoclonal antibodies bind to Pdl1 or PD-1 and cause reversal of T cell exhaustion. So these T cells that are already in the system and start exerting anti-cancer effects and their experts. So in our clinic now uses this algorithm for patients with metastatic lung cancer, for squamous cell lung cancer, and this is the treatment algorithm for metastatic non-small cell lung cancer now. For patients with non-squamous, everybody gets the NGS testing. For patients with squamous, if they are never smokers or have an adenosquamous histology, we do NGS, otherwise we will just do Pdl1 expression. If a patient has a driver, we give them targeted therapy. If the patient does not have a driver, we give them immunotherapy by itself or in combination with chemo or just the combination of ipilimumab and nivolumab. For patients with Pdl1 expression greater than 50%, for vast majority of the patients, we would use immunotherapy alone. Why? This is the KEYNOTE-024 study. This was looking at pembrolizumab in high Pdl1 expressors, greater than 50% expression. And here, pembrolizumab alone causes a 5-year survival of 32% in metastatic lung cancer. The KEYNOTE-189 study looked at combination of chemo with pembrolizumab in non-squamous lung cancer. And here, the 2-year survival rate was nearly 46%. So these studies show that long-term survival is possible with immunotherapy in patients without driver mutation. We also now know that the combination of ipilimumab and nivolumab is effective in the frontline treatment of non-small cell lung cancer. This is based on the Checkmate 227 trial. Here we showed that both in Pdl1 positive and Pdl1 negative patients, there is a substantial improvement in overall survival. These are just data from Pdl1 negative patients, where the 4-year survival rate is 25% with Nivo plus Ipi, and in squamous histology, the 4-year survival rate is 22%. As we know in Pdl1 negative patients, chemo plus immunotherapy alone has some effectiveness, but perhaps the effectiveness is most impressive with Nivo and ipilimumab based on the Checkmate 227 results. So for Pdl1 negative patients, this combination merits our consideration. So in our clinic, for patients without a driver mutation, if the Pdl1 expression level is greater than 50%, we use PD-1 or Pdl1 inhibition as monotherapy. If the patient have high disease burden or symptom burden, we would use chemo with IO. In the 1 to 49% group, chemo plus pembro or Nivo-Ipi are appropriate. In the less than 1% group, I would think about Ipi-Nivo as a combination approach. Now we know that patients who benefit from immunotherapy are a subset of everybody who gets it. only about 20 to 30% have long-term benefit. The rest of the patients unfortunately have disease progression. And for these patients, docetaxel is the standard approach. Median survival when you give docetaxel plus ramucirumab is approximately 10.5 months. This is a group where novel combination approaches are needed. There are thankfully a number of approaches that are currently under investigation. These are meant to reverse resistance to immunotherapy or turn an immune microenvironment from a cold tumor microenvironment to a hot tumor microenvironment. What it means is a hot tumor microenvironment will respond more readily to manipulation of the immune system. So there are a number of ongoing clinical trials that looks at combination approaches that build on the effectiveness of immunotherapy for patients with advanced stage non-small cell lung cancer. So in summary, I hope I've been able to show you that in the past 5 years, we have seen substantial improvement in treatment approaches for patients with non-small cell lung cancer, and therefore better outcomes and better survival for patients. There is no doubt that the introduction of immunotherapy and new targeted therapies have resulted in improved clinical outcomes. Molecular testing is an important part of patient management for non-small cell lung cancer. So using both tissue-based and liquid approaches are important, and using them judiciously to get at a molecular diagnosis is critical. And finally, immunotherapy resistance is being studied extensively with novel treatment approaches. And it's hoped that these approaches will start bearing fruits in the near future. With that, I will stop and let me any questions. Thank you so much for your attention, and thanks again for the opportunity to speak to you today.
Thank you so much, Professor Ramalingam, for this elegant presentation. And now I have a question for Professor Drew, if he's with us online. Professor, thank you so much for your elegant presentation. Actually, I have a question concerning the treatment, the consolidation therapy in the patients in stage 4 with oligometastasis metastasis. You mentioned 2 studies with small number of patients. However, I would like to know some details about these patients, whether the oligometastasis replace the response after drug A. Was it complete response in the metastatic site, so we proceeded to the consolidation therapy after that, or actually it's a very interesting topic and I would like to ask about it.
Sure. Greetings from the other side of the planet, where it is 7 a.m. So right now the evidence is for cleanup radiation for remnant or persistent disease. The Oligomes trial is probably the better trial to look at. There was a similar trial done at UT Southwestern. Both of these trials were closed early because the effect was so big that it was found to be unethical to continue. And in both of these studies, the 4 cycles of systemic therapy was given, and what remained behind was cleaned up with radiation. It is a little bit more controversial to think about giving Sbrt or other local therapy if the tumor is progressing while they are on systemic therapy. And the main reason is because we might see 1 or 2 lesions growing. There might be 15 to 20 that are about to grow and we just can't see it. And this is where blood markers will help us discern when to treat progressive patients. But right now, the evidence is the strongest for the patients with persistent disease.
Okay, thank you so much. We have a question from the floor.
Regarding radiation of the persistent disease, do we radiate the primary or the metastatic persistent disease, or the metastatic persistent disease only, or that lesions that are mildly increased in size but still in the stationary disease by criteria?
Thank you for the question, because it is not always black and white. Right now, the leading hypotheses are to cytoreduce everything you can see. So this presents a problem if you have too many lesions. In my practice, if there are, let's say, 5 or 6 large lesions, I just don't do it. I don't treat part of the cancer and not other cancers, because we're trying to invest in the patient to live an extra 1 or 2 more years than they would. So we assume that the systemic therapy has eradicated the cancers that are sensitive, and the radiation's role is to clean up everything that was resistant, because what's left behind is resistant. And if those resistant cells spread to more metastases, then you just have more resistant metastatic sites. So we try to treat everything that we can see.
And regarding the bone metastasis and treating it with SBRT, actually I was surprised by this, because we don't have the luxury of doing this, either due to the tumor load burden on the machine and the quality of the machines that is highly expensive, and the quality assurance that should be done for every patient with each session of SBRT, that makes the time of SBRT session equivalent to a time of treatment of 10 or more patients in the conventional setting. If there is a big difference in the quality of life and the outcome for this patient, because especially we are still palliating, and long-term effects of the radiotherapy may be shown to the patient due to the short survival time. So I would like to ask...
Can I ask you a question?
Yes.
Right now for palliation, if you're using APPA beams, how many fractions do you commonly deliver?
Actually, 1 is the maximum of 5.
Okay, so then you're not going to necessarily save time. For tumors that are near the spinal cord, of course, you need high technology and quality assurance, and there are some software systems that make life a little bit easier, but it is always going to be more time. But if the tumor is not near the spinal cord, basically just use more and more fields. And we can call it SBRT if we want, or we can just call it multi-field conformal. And if, with APPA, maybe 8 or 10 gray is all that we can deliver, for example, to the humerus or the femur. But if you were to use 3 or 5 fields, then there's no reason why we can't give 12, 14, or even 16 gray in 1 fraction. There is a randomized trial from MD Anderson that looked at this. Their comparator was 3 gray times 10 versus a larger single fraction, and the larger single fraction definitely had better pain response and pain control durability.
Thank you very much.
Thank you so much. Any more questions from the floor?
Hello, Dr. Drew. I don't know if you remember me. I met you at our conference a few years back in May as a lead. Hello. I just wanted to ask you about your personal experience, because we know, of course, you're such high caliber, of course, with ultracentral tumors. How is it the challenge of giving the radiation, and do you combine it with other drugs, and what is the worst, perhaps, side effect that you've seen in your own personal experience?
So our letter right now is undergoing review in the Red Journal, where we try to explain what we think happened in that trial. Some of the centers, these were in Europe, used 10 to 15 millimeters for their margin expansion around the tumor. So if a tumor is close to the cartilage of the trachea or the carina or the central bronchus, it is also close to some major pulmonary vessels. And we think it's the injury to the vessels and the cartilage that's causing these problems. And I think the simplest solution is don't give SBRT doses. Don't give any more than 4 gray per fraction, for example. So that's the simplest solution. But if one really wants to give higher doses per day, 8, 10, I wouldn't go over 10. It would be to not treat with a large PTV expansion, and you need to have good tracking techniques. Tracking is very difficult for lung cancer without fiducials. I mean, we're very lucky to have MRI machines, so I can see it, but that's not usually the case. So my recommendation would be stop all the systemic therapy for a few weeks before and after, and then deliver no more than 4 gray per fraction, and use the best, talk to your physicist to get the tightest field so you can maybe only add 5 millimeters instead of 10 to 15 millimeters. And I think that was, those pictures that I showed, those were some very large fields. I would not be comfortable delivering SBRT doses to such large fields.
Thank you, sir.
Any more questions from the floor? Okay, I have my last question concerning the SBRT for the suprarenal lesions. If we have, sometimes we have a primary tumor which responded well to the treatment, and we have a small suprarenal lesion. So some studies are addressing the SBRT to the suprarenal, to this small lesion. So can I know your experience and how do you think about that? Shall we go for this?
Yes, especially if it's on the right side. On the left side, we have to be careful of the stomach. But it's the same principle. We want to clean up everything that the systemic therapy wasn't able to clean up, and that will, then you allow, again, drug X to continue to treat all the microscopic disease.
Okay.
So where it is, I don't think matters so much as thinking about the biology, that we want to clean up the remnant disease.
Okay, thank you so much. No more questions? Okay, thank you so much for your time, Professor. Thank you so much. And by that, we will close that session.